So the next topic, the role of hormone therapy in the treatment of prostate cancer. Speaker, Professor Milnagus Jievaltas from Lithuanian University Health Science, Kaunas, please.
Good afternoon, dear colleagues. Thank you for the invitation and the possibility to talk to your auditorium. My topic today is ADT and current thinking on androgen deprivation therapy in modern era. Actually, it's not so easy to say something very new about therapies which exist for almost 60 years. Actually, castration or ADT was established, was investigated and proved the effectiveness almost 60 years ago. Until now, this therapy was awarded 2 times by Nobel Prizes. So, as I said, I can say probably very shortly about ADT that ADT is nothing very, very new in the field, but still that therapy is almost the background for systemic therapies, for modern systemic therapies. My speech today will focus on few points, and let me go through them. First of all, the testosterone is probably the main substance in pathway of prostate cancer growth. Testosterone regulate transcriptional processes in nucleus of the prostate cells, and in that way it might stop growth or stimulate growth of the prostate cells. In case of the cancer, we typically treating cancer, we would like to diminish the growing processes in the cell. So the main method is to remove the testosterone from the blood in order to diminish the dihydrotestosterone and stop translational processes in the prostatic cell. Discoveries of new pathways in recent years very well are incorporated in our general understanding of the prostate cancer cells hormonal regulations. All these discoveries also let us use new substances in the treatment like Enza, Abi, Daro, and other drugs. Also, these new pathways, this new mechanism let us better understand the mechanisms of castration-resistant prostate cancer, as well as hormone-sensitive prostate cancer, and of course, it helps us to improve our treatment modalities. Coming back to the ADT, in experimental models, the scientists show that if we have castrational level of the testosterone, in such circumstances, typically prostate cancer cells, they stop their growing, like this yellow C curve. And in opposite, if we have growing testosterone concentrations, typically we have growing prostate cell in tissues. And we can also find the analogy in our clinical practice. Look, in this trial, the patients who do not reach their testosterone castrational level, their survival curves typically are worse in comparison for those who have very deep testosterone suppression level. So absolutely clear that if we have deeper compression, deeper suppression of the testosterone level in prostate cancer patients, it typically reflects to the better treatment results. Another one study also showed that actually the less than 30 nanograms per deciliter testosterone level in the serum represent a good clinical parameter for better prognosis. Actually, the 50 nanograms per deciliter is the borderline for registration of the LHH analogs, which are coming to the market. But we have improvements that deeper suppression of the testosterone better results on survival. Another one, analysis of existing trials show that less than 20 nanograms per deciliter testosterone level correlates with better survival data, but in the same time, so-called breakthrough or escapes from testosterone castrational level also might be predictor of lower progression-free survival. And that also can be the prognostic factor for more aggressive disease. Castrational level of the testosterone at the moment, we have three methods what we are using in clinical practice. We can do surgical castration or use LHRH agonists or LHRH agonists. All of them, they have their own advantages, but in the same time, they have some disadvantages. They are a little bit different. But in the same time, I should point out that there is no level 1 evidence in favor of a specific type of therapy. It seems that all these therapies provide quite similar clinical results. If there is some differences among surgical and medical castration, clinically, it seems that the results are very, very, very similar, but actually, theoretically, some differences should be. When we are doing surgical castration, we are acting on the level of the testis. We are just removing the glands which are responsible for the testosterone secretion. When we are using the drugs like LHRH agonists, we are acting on pituitary gland level. In the same time, we should stress out that that is a systemic effect. If we are trying to compare these two methods from point of testosterone suppression level, it seems that drugs might suppress testosterone even in higher level than castrational situations. Two different trials, they have the same conclusion. LHRH analogs suppress testosterone more. An explanation for that is probably the adrenal gland. We should keep in mind that adrenal gland is responsible approximately for 5% of secretion of the testosterone in the body. And in case of the surgical castration, still adrenal gland is responsible for some testosterone production. And also there was discovered the mechanism how the cells by itself, I mean metastatic cells by itself, might produce also intracellular dihydrotestosterone. So we never reach the zero level of the testosterone in the bladder, in the serum, and that might be one of the explanation how the refractory cancer developed. Is it important to maintain low testosterone level? From that point of view, interesting this study, the scientists show very clearly that patients who has so-called breakthrough or escapes from testosterone castrational level, they have worse survival data in comparison with those patients who do not experience these escapes. And the borderline, the level of the testosterone in that particular trial was 32 nanograms per deciliter. And so the escapes from testosterone castration level might be good prognostic factor for worse prognosis of the patients. But if we look to the different drugs what we use in our everyday practice, they have different incidence of these escapes from testosterone castration level, and from that point of view, it seems that these drugs are different. When we are choosing the medicine, what to use for ADT, typically we base on efficacy or convenience or tolerability of the drugs. And as I said, it seems that there is no major differences among these drugs. And actually, we are lacking good tete-a-tete comparison trials. We needed these trials. I look at one of the recent trial from Korea that is a retrospective trial where they tried to compare few typical medicines. Goserelin, triptorelin, loprolide was compared in the retrospective analysis how they might compress or diminish testosterone production in the serum. The groups were not very well balanced. They were different, but according to the main clinical characteristics, the group were not so different. So probably some conclusions we might do from this trial. And by the result of the trial, finally, the investigations show that in the beginning of the therapies, probably the suppression of the testosterone is very close to each other, very similar in the groups. But in the 9 months duration, the differences appear among the groups, and some drugs compress the testosterone more. And let's say goserelin produce the weakest compression of the testosterone. And especially that is the true if we choose very deep compression of the testosterone. If we look at the group where testosterone is less than 10 nanograms per deciliter, there only a third part of the patients reach this level, and luprolide and triptorelin cause better results. So it might be that some differences exist, but from such small trial, it is difficult to find these differences. And according to the side effects, adverse events, also there was no big differences in the group. So finally, we should stress out that applying the principles of evidence-based medicine, it is not appropriate to assume a class effect between different LH agonists. Also, I stress out that we should keep in mind the side effects of the therapies. All these side effects should be managed in proper way. We should send them in time manner for our colleagues, cardiologists or endocrinologists, in order to balance all these side effects and guarantee better quality of life of these patients. What about the current situation with pandemic? In COVID era, last 2 years, it seems that the longer depots, like 3 months, 6 months, or 12 months depots of LHRH analogs, it seems that they are preferable drugs because they might cause less injections, less visits, less PSA tests, and of course it might spare our time and also time of the doctors. But from an epidemiological point of view, that is what the epidemiologists are asking from us, to do less contacts with our patients. So we should use probably longer depots for the treatment of the patients. And finally, my focus is about the modern era. If the new discoveries, new drugs change something in ADT, it seems that do not change so much. ADT still remains the background of the therapy, systemic therapy, in case of progressive prostate cancer. It still should be used even in the castration or resistance situation, regardless of any additional therapies. And if we look at all these new substances, I should stress out that all of them, they were investigated on top of ADT. ADT always should be continued, and adding some new therapies, we can also add some benefits in survival for our patients. So ADT is still backbone for systemic therapies. And we can find also reflections of that statement in all most popular guidelines like European, American Neurological Association, or NCCN guidelines. They stress out that we should maintain castrational level of testosterone lower than 50 nanograms. We support the standard of care to maintain castrate testosterone level even in face of resistant cancer. And now let me look at the 2021 European urological guidelines. In case of high-risk localized disease, still long-term ADT together with radiation therapy have very, very strong recommendation to use 2 or 3 years hormonal therapies. Monotherapy with ADT should be used only for the patients who are unable to receive radiation therapy, and that is quite clear, strong recommendations. New trial 2021 looking at what is better, adjuvant hormonal therapy or neoadjuvant hormonal therapy. It seems that they find some advantages for adjuvant hormonal therapy in case of irradiation of the prostate for prostate cancer. For patients with N1 disease, now we have, let's say, selective therapy according to the risk factors. For the patients with few nodes, less than 2 nodes, positive nodes after the surgery, the first suggestion is not to start with ADT, but probably first just observe the patient. And if we have more aggressive disease, 3 and more positive lymph nodes, so probably to start with ADT together with irradiation of the zone of the surgery. Recommendations are not very, very strong, but all these tactics we already use in our everyday practice. And for hormonal therapy in case of metastatic disease, hormone-sensitive prostate cancer, also there is a recent 2 or 3 years a new statement that ADT as a monotherapy is not sufficient. We should use combinations, and combinations with chemotherapy or new androgen therapies, new drugs like abiraterone, enzalutamide, apalutamide, or for oligometastatic disease, use combination of ADT plus radiation to the primary site, to the prostate. Radiation to the metastatic sites is still experimental approach, and look, the recommendations are strong. And last year and this year, new trials appear telling us that even triple therapies, when we are comparing 3 different therapies like, let's say, ADT plus chemo plus abiraterone plus radiation, also might add some benefits to survival. And so I guess that in nearest years, we will have new evidences to use not the combination of 2, but probably even 3 therapies. But the sad story is that still probably more than half patients with newly diagnosed prostate cancer with metastasis, so-called the hormonal sensitive setting, almost half of these patients still are treated with just ADT monotherapy, And typically that is the fact because some patients are too old or they are too morbid and we can't use combinations. But it seems that in nearest future we will have more possibilities, more methods on the table. And finally, let me conclude. Increasing evidence supports that androgen suppression increases overall survival, and that's a valid therapy. Cutoff levels of testosterone still is debated. 50 nanograms versus 20 nanograms is a different levels which might cause different survival. So we think that 20 nanograms, very deep suppression of the testosterone, is a significant prognostic factor for better survival. ADT is the current standard of care in metastatic prostate cancer with LHH agonists, treatment resulting in lower serum testosterone than orchiectomy. ADT should be backbone therapy in hormone-sensitive prostate cancer and used in combination with, when we are talking about metastatic cancer, it be combined with DOTSI, API, ENZA, APA, and radiation therapy. Applying principles of evidence-based medicine is not appropriate to assume a class effect between different LHH agonists. It seems that all of them are effective. Long-lasting formulations like 6 months or 12 months depots may help provide the optimal treatment for patients and ensure they achieve adequate suppression and reduce patient health care interactions among these patients. So thank you for your attention. That was my today's speech, and I'm waiting for the questions in case if they are.
Thank you very much, Professor, for your lecture. I would like to ask you about what is amount of surgical castration in your hospital and what types?
We are using surgical castration in case, I don't know, probably less than 10% are castrated surgically, and typically in case if they have difficulties to come to the hospital, let's say with amputated legs, or they have they are too morbid, let's say, the ECOG status is very high, and they can't move. So for these patients, we prefer to do surgical castration, but actually less than 10%.
And is subcapsular enucleation is popular?
Yes, some doctors prefer subcapsular, some doing castration. Personally, me, I'm thinking that castration should be done. It is a little bit quicker, it's a little bit less complications, and that's what we should do for our patients.
So
But actually, I do not believe that exists some, let's say, clinical differences between what you are doing. According to my theoretical lecture, probably there exists difference between pharmacological castration and surgical castration. Actually, we should focus more deeply on that point. When we start ADT, we typically very seldom check the testosterone level. Probably we should do that, because as I said, different medicines cause different suppression of testosterone, and also if we use, let's say, 1 month or 3 months depots, it means that probably we have more escapes from testosterone castrational level, and that might be the cause of quicker development of castration resistant cancer.
Thank you for your answers very much, and as I don't see any more questions, thank you.